All right. Hello, everybody. Thank you so much to everybody who has joined us tonight. My name is Savannah. I'm on the marketing team here at Seaview Orthopedics. If you aren't super familiar with us, we are an orthopedic practice and have been around for over 40 years taking care of the Jersey Shore. We've grown over the years and currently have 6 office locations: Ocean, Freehold, Homedale, Brick, Barnegat, and Monroe, and we will be growing. So, we are excited to be hosting another edition of our virtual education series, and we're really excited to have Dr. Collins on with us today to share his knowledge. For those who don't know, we do these virtual education seminars every other month. So, information can be found on our website under the About tab or in our news section on our new homepage. You can also stay up to date with all things Seaview by following us on our social platforms. We are at Seaview Ortho on Facebook, Instagram, TikTok, LinkedIn, and YouTube. So before I jump right into it, I just want to go over a couple things regarding the platform. So right now, everybody should be muted. I ask that you do stay muted throughout the presentation. If you do have any questions that pop up while Dr. Collins is speaking, please write them down, or you can feel free to put them in the chat. If you look on your bottom right-hand corner, you'll see the little chat bubble icon. You can click in there and we will have a Q&A session following the presentation. So once I announce that Q&A session, you can feel free to unmute your mic to ask your question, or you can type it in the chat and I will read it for you. This presentation is being recorded. It is going to be sent to your emails after in case you want to rewatch or share with a friend. With that in mind, please try to keep all of your questions as vague as possible. We don't want anyone sharing any personal health information here. Um, so if there's anyone that you know that couldn't make it, feel free to share them the link afterwards as well. So now for the reason that we are all here, I'm gonna intro Dr. Collins real quick. So Dr. Christopher Collins specializes in general and pediatric orthopedic surgery. He attended medical school at Texas Tech University Health Science Center School of Medicine and graduated in 2010. He then did his residency at Rutgers, New Jersey Medical School and earned his fellowship at Orlando Health Arnold Palmer Children's Hospital. His area of expertise includes pediatric trauma, treatment of spinal deformities, treatment of congenital and syndromic musculoskeletal disorders, treatment of hip dysplasia, and treatment of pediatric foot disorders. Dr. Collins' philosophy for patient care emphasizes the unique needs of children compared to adult orthopedic problems. He also stresses thorough discussion with the patient's family so that he can develop a treatment that will work for both the patient and their family. So without further ado, I'm going to pass our virtual mic over to Dr. Collins for the presentation.
Thank you very much. I appreciate the intro there. Good evening, everybody. Thank you for joining us. I know it's a pretty nice evening outside, so we'll try to get through things as quickly as possible so we can get to the question and answer, and hopefully we'll have some really interesting questions afterwards. So if you bear with me, we'll walk through a few of these slides together and go over a few of the common shoulder injuries that I see as part of my practice. Let's get this slideshow started. So, what are the more common types of shoulder injuries? We'll get to that in a second, but let's talk a little bit about how common shoulder injuries are. There's a few different studies out there that have looked through how many injuries that occur, but more recently, a good study of high school sports has kind of looked through all the different sorts of injuries that kids get, and quite a few here in America, well into the 200,000s. And in general, these, shoulder injuries tend to occur more when kids are being competitive as opposed to practice-related injuries, but certainly can happen during any sort of athletic pursuit. But when it comes to what are the more common sports that cause these injuries, well, the usual suspects, at least here in the United States, include football, but absolutely wrestling. And then for a different type of injury pattern, our baseball players. So those are our kind of 3 more common injury patterns. Although certainly if they had looked at it, I would include likely cheerleading and gymnastics as well as far as the top most common ways in which kids get these sports-related injuries. And as you would expect, the vast majority of these injuries, about 40%, are just sprains and strains and don't need much treatment other than symptomatic. But as far as The more serious injuries, dislocations and separations outweigh things like fractures and even contusions. So it happens a lot more frequently than you may think, and sometimes it can be pretty subtle. Partial dislocation, partial separated shoulder, AC sprains that may seem like a sprain, but more of an injury to the joint than you would expect. As far as the mechanisms, the vast majority happen on player-to-player contact, typically, being tackled or running into somebody or being pushed into a wall, like in our hockey players. But a fair amount also, of course, happen with a fall to the turf or fall to the ice in hockey, where you're making player contact with the surface, about 23% of those injuries. So, just to give you a brief anatomy, we're not here to go through medical school together, but the shoulder joint is composed of three different bones. The socket, so to speak, is actually what we call the scapula, and it starts as a triangular flat plate and then kind of works its way towards the actual joint socket. It's not as much of a socket as it is really more of a flat plate. And the upper portion of your humerus bone forms a ball that sits on that plate. And it's an inherently unstable joint, just as the bones themselves. That's what allows us our wonderful degrees of motion and ability to reach above our head and around our back, because the joint really does have a lot of degree of freedom of motion there. If you look on the right side there at that picture at the back of the shoulder, what we call the posterior shoulder joint, you can see a little spine that separates the triangular plate there. We call that the spine of the scapula. And that actually rotates all the way across the top of the shoulder joint. And you can see on the left view at the very top there, that label called the acromion. And that little projection from the shoulder blade actually forms a joint with your collarbone, which we call the clavicle. It's another very common injury for shoulder injuries, is that what we call acromioclavicular joint, or AC joint for short. If you look at the next slide here, there are a few different muscles that hold that ball onto the plate. Like I said, the joint's usually inherently unstable, so we need structures to stabilize it. In addition to just the joint itself, there are muscles that attach from the plate, the scapula, all the way out to the side of the humerus there. We call that collectively the rotator cuff. And in general, you may hear a lot about that in adult sports injuries. If you watch any sports, rotator cuff injuries, very common in adults, not as common in the pediatric and adolescent population, as they don't typically get the same wear and tear, but it can happen if kids do a lot of repetitive microtraumatic injuries like football or even just working out a lot. You can see different labels for the four different muscle groups that make up the rotator cuff, but the main one that you hear about with rotator cuff injuries is the supraspinatus muscle that runs between the acromion and the top of the humerus. Very commonly, that tendon and muscle can get pinched between those two bones, which can lead to some wear and tear. On the next slide here, you can see there's a lot of muscles that cover over those rotator cuff. Along the collarbone and that lower portion of the image, you can see above it, there's a muscle called the trapezius, which attaches to the back of the neck and then also the back of the spine. And then, of course, there's also muscles that attach the front of the neck to that collarbone, and that allows us to elevate the collarbone up. But it also provides a point where, when there's an injury to the collarbone, it may tug the neck down and cause some very characteristic exam findings after injuries. And of course, along the bottom side of that collarbone, you can see in the front view at the bottom there, your pec muscles, which are involved with power weightlifting, as well as what's called the deltoid muscle, which allows you to bring your shoulder out from the side, attached to the other side of that collarbone. And again, along the back, you can see the trapezius muscle there attaching to that spine of the scapula. So that trapezius, along with those neck muscles, allow us to actually elevate the shoulder blade and not just the shoulder joint itself. So there's actually multiple degrees of freedom and motion in the shoulder, where we're not just moving the joint between the shoulder blade and the humerus, but also moving the shoulder blade along the back as well. So there's a lot of motion that can occur in the shoulder blade, and that's what allows a lot of these injuries to occur, all these degrees of freedom. All right, the next slide, I just want to talk a little bit about some of the common shoulder injuries I see in my practice. As a pediatric doctor, of course, I see a subset of injuries that are not as frequent as we see in adults. Certainly, clavicle fractures can happen in adults, but much more commonly in really young children, so under the age of 3 or 4. That's our typical fall off changing table or fall out of bed. But in my older teenagers, it typically happens from a much higher impact sort of sports related injury. Another common injury that I see are proximal humerus fractures. So the actual shaft of the humerus getting injured right where it attaches to the ball up at the top of the joint. And then shoulder dislocations and shoulder instability is another thing that I see in my practice, not only from just direct injuries, from repetitive trauma as well. And then finally, the acromioclavicular ligament and joint sprain. And then a final topic that I see a fair amount that you don't think of as an injury, but it really is. It's little leaguer's shoulder or growth plate inflammation from a lot of my overhead throwing athletes, especially pitchers. So let's get into clavicle fractures. So the funny thing about the clavicle is that it is really the first bone that forms actual bone out of the cartilage. As you know, in the womb, we're mostly just little squishy cartilage, and as we start to mature, that cartilage slowly turns to bone, and it's one of the first that actually starts to form that bone. You can see there on the little picture inset that that clavicle is quite small in our little ones, especially under the age of 3, and it's very easily injured just because of the actual size. But as we get into our teenage years, it becomes a much thicker bone and it takes a higher energy injury to injure it. Another funny thing about the collarbone, though, is it's actually the last bone to stop growing in your body. So it's the first bone to form bone, and then the last one that finishes growing. So there's a lot of growth potential in the collarbone, although most of the growth occurs before teenage years. The nice thing about the collarbone, though, it also has a very thick outer covering. We call the periosteum. In kids, it's like a leather shell around the bone. And that actually holds a lot of stem cells that allows the collarbone to actually remodel and actually straighten itself out, even from a really serious fracture. Next slide here. So, how do you injure the collarbone? Well, it's the usual typical lateral fall onto the shoulder. Oftentimes in football, it also occurs that somebody lands on top of you. So, you not only get the blow from yourself hitting the ground, but the other person hitting the other side and forcing it further into the ground. Generally, on exam, it can be quite subtle, although with really bad injuries where there's displacement of the fracture, you can see that the shoulder will droop down and that the arm will be held downwards, and then the neck tends to slide towards the side of the injury because, well, the muscle's still attached to the collarbone and pulling the neck to that side, and it hurts to try to elevate and raise those up. Of course, you can also see swelling and pain about the collarbone, and even sometimes some bruising in more seriously displaced fractures. Of course, the diagnosis is pretty straightforward. You get some x-rays and take a look. Sometimes, though, towards the end of the collarbone where it attaches out onto the shoulder blade, that can be a lot more subtle and it may just look like a sprain. In fact, I had one of those earlier this month that was for sure a sprain, and then it turned out 2 weeks later when it was still hurting a lot that the x-rays were starting to show new bone forming there, indicating that there was a subtle fracture about the tip of the growth plate on that collarbone. So how do we treat it? Well, the old standby is the sling, and in general, as you can see here in the picture, it tends to be pretty effective. Even up until in the early 21st century, a lot of people still preferred to utilize what's called a figure-of-8 brace, basically a harness that goes around the back of the shoulders and then pushes onto the collarbone to try to reduce the fracture. In general, we have found that that is not any more effective than sling and doesn't lead to faster healing, but of course, it also leads to worsening of pain. So for my kids, I generally don't use the figure-of-8 brace, although some providers and some urgent care still have them around and sometimes prefer to use those. And it certainly isn't any worse, but why have our little ones in pain if we can avoid it? As far as healing time goes, it really varies based on age. My really little ones under the age of 3, it can heal as quickly as 3 or 4 weeks. Our newborns, almost, who get their injuries coming out of the womb, can heal in 1 to 2 weeks. But in general, for our really young ones under the age of 8, it's about a 6 to 8 week recovery, and in general, only being painful for the first 2 to 3 weeks, though. For our adolescents, tends to be closer to 8 to 10 weeks, and in our older teens, it can be almost 2.5 to 3 months before it's really fully healed enough to undergo contact sports. In general, though, I will usually let kids start to do some range of motion around the 4 to 5 week mark, and perhaps utilizing a sling when at school and then taking it off at home in that period of time. Generally, I'll get x-rays either at 3 to 4 weeks out from the injury and then subsequently at the 6 to 8 week mark, depending on age, to document the healing process. So, when do we operate on collarbone fractures? Well, this is a really controversial topic, both in adults, but also, of course, in kids as well. Looking at pediatric surgery rates for collarbone fractures, even up into the late 20th century, it was extremely rare to operate on pediatric and adolescent and even teenage collarbone fractures, only about 1 to 2% of fractures would ever undergo surgery. However, those rates here in the 21st century have jumped, and about 17% of overall pediatric fractures have ended up undergoing surgery nowadays, and almost 32% of ones that are what we call displaced, like you can see up here in the picture. So why are we doing that more frequently? Well, it actually reflects an adult trend towards surgical treatment. And there's some adult studies that have shown faster healing time as well as lower rates of non-union, meaning the fracture heals more frequently with operative fixation. However, even in adults, the functional outcome between operative and non-operative treatment has usually been shown to be the same. However, if you look down at that third bullet there, no pediatric studies have really shown any benefit of operative treatment for pediatric patients for collarbone fractures, and even really displaced fractures can oftentimes heal because of that remodeling potential we talked about earlier. So when do I operate on them? Well, usually it's on my older teenagers and kids that have fractures that have what we call shortened. So the fracture goes from here and then slides over itself, like you can see in the x-ray in the top right. And I'll do that in kids who are throwing athletes, and certainly I'll even consider it in my gymnast as well, so they put a lot of pressure through the shoulder and perhaps leads to better outcomes for them. Although I can't say that I necessarily seen much change functionally, but it's always something you discuss with the individual family to see what their preference is. All right, so what's the next topic? Well, what we call the proximal humerus fractures, basically the ball separating from the shaft of the humerus. It can be quite subtle, and in my younger kids, usually just a little bend, but in my older kids, you can see a complete separation like you see here on the picture. The nice thing about the proximal humerus, much like the collarbone, it's one of the last growth plates that stops growing, and it is one of the more powerful growth plates in the entire body. So, in addition to finishing growing really late on, it actually can heal and remodel quite rapidly due to the rapid growth of this growth plate. In general, though, it does finish growing somewhere between 16 and 19, depending on age and gender. Injury mechanism is more or less the same as collarbone fractures, fall into the shoulder. My younger kids, though, it can just be a fall on outstretched hand. It doesn't even take quite a lot of pressure, depends on how they hit it. And in general, it's the similar sports, hockey, football, gymnastics. I have some horseback riders as well, for whatever reason, tend to get more of an injury in that direction. Usually, these happen more from a fall onto the top of the shoulder as opposed to direct blow to the side. But in general, it's some form of a fall on that arm. As far as the exam, kind of similar. Usually they don't droop as much as our collarbone fractures, but they tend to have pain and swelling, and oftentimes can have a lot of bruising along the side of the shoulder. And as far as our primary providers, one important thing to look out for is to test sensation over the side of the shoulder where the axillary nerve controls sensation there, as sometimes there can be an injury to that nerve that may be quite subtle. Hard to test the motor function of that nerve because, well, it hurts to do that because of the broken arm. But if you can at least test sensation, you can tell that the nerve is intact. Still pretty rare injury, though. So, as I was saying earlier, the remodeling potential for proximal humerus fractures is quite robust. You can see here in picture A how significantly displaced and even shortened, and really those fracture fragments are not even touching, and that growth plate starts to attach itself back on pretty quickly. You can see in picture C, this is just, I believe, a few weeks later. So yeah, that's 3 months out on D, and then on C, it's like 6 weeks later, and how much it's already remodeled just from the power of the growth plate there. So in general, it's pretty rare that we need to operate on these because kids will remodel it quickly. Although if it's this displaced, you'll often see some functional decrease in the ability to elevate the shoulder out to the side. And that may take some time to get that back because of that remodeling that has to occur. So how do we treat it? Sling is certainly reasonable for really young kids. In our older kids with severely displaced fractures, sometimes putting a cast on and then hanging it off of the neck will provide a little downwards force. Gravity will pull the arm out to length and reduce the fracture a little bit. And then try to get them out of that immobilization after 3 or 4 weeks once everything's starting to get sticky at the fracture site and they can start to move things and do some gentle range of motion. With increase of overhead activity, depending on how much remodeling they need, usually somewhere between 2 to 3 months as far as return to sports. So when do we operate on these? Well, pretty rarely. It tends to be in kids with a lot of displacement and older kids that don't have as much remodeling. And then, of course, the old standby of patient preferences and parents that would prefer to have fractures anatomically reduced. course, if there's nerve injury, sometimes reducing the fracture more quickly can lead to improvement of that nerve function. But in general, it's pretty rare that I end up operating on these. I'd say perhaps a handful of times in my career if we needed to do this. But in general, we try to do a percutaneous procedure like you can see on that picture B on the far right. Basically, just realigning things and putting pins through the skin to keep it there, and then remove the pins in the office in 3 or 4 weeks once everything is getting sticky and healing up. So, third injury that I see quite frequently, and it looks like it didn't bring in my picture of the injury, but it does show my externally rotated shoulder here. I'm not sure why that didn't get brought over when we uploaded the presentation here. But in any event, shoulder dislocations can happen in one of a couple varieties. The more typical that we see is what's called an anterior dislocation, and it typically occurs in what's called the abducted and externally rotated position, as you can see in the picture here, kind of a claw up in the air, and the arm gets hit and then wrenched backwards, causing the ball of the humerus to slip off that little plate and go forward. The other dislocation is more the shoulder getting pushed backwards, and it's usually due to like repetitive micro trauma. In general, people that are getting their arms pushed backwards frequently, it's almost exclusively my football linemen, and I would say, of course, people that are doing excessive workouts too, so bench press. So that's more of a repetitive thing as opposed to an acute injury. Of course, the real textbook definition of posterior shoulder dislocations, at least in adults, is seizure disorder. For whatever reason, the writhing that they have on the ground can oftentimes dislocate the shoulder posteriorly, although not necessarily a traumatic thing, of course, that we're talking about. So on the next view here, you can see what we do for the workup. In general, it's to get an x-ray to show where that ball is in relation. The most helpful view usually is this one here on the far left called the axillary view, basically where we're looking at the x-ray straight down onto the shoulder, and that can tell us where the ball has gone, either forwards or backwards. In this case, what we see here on the x-ray is an anterior dislocation. On the two side views here, you can see that the ball doesn't really line up with the plate, especially on that far right view, what we call the lateral Y x-ray, and that it's slipped forward compared to the rest of the shoulder. Of course, physical exam findings are very typical as well. Typically hold the arm close into the body and don't want to try to elevate things because quite honestly, the shoulder can't move in that direction when these occur. So what are the treatments? Well, it's pretty medieval and it hasn't changed a whole lot in the last few hundred years. Of course, you can see whenever anybody has the name Hippocrates on a slide, that means this is at least dating back to the Greeks of how we treat these. The usual method that we do nowadays is to take the patient in the ER and do some sedation to relax the muscles and have one person with a sling across the chest pull some traction and then the medical provider pulling on the arm to try to basically pop it back into place. It isn't a very benign process, but there are other ways to do that. The Hippocratic technique, just basically put your foot in their chest and yank really hard. Not something that I typically try to do because it's quite violent and may result in further injuries. And then the less violent Stimson technique you can see down here at the far right, where we have the child lay in the prone position, usually with some form of muscle relaxation, and we just hang a weight to see if it'll stretch out the muscles, allow the muscles to relax, and just the shoulder to pop back into place. For a first-time dislocation, I'll usually just treat it with a sling for about 2 to 3 weeks, and if symptoms persist past that, we'll even do some physical therapy. So where do the real problems start to happen? Well, with recurrent instability. So sometimes, even after a dislocation, there will be ways for that shoulder to continue popping out. There are different lesions that can occur as the ball pops off the socket here. Here on that far left picture, you can see what's called a Bankart lesion, where part of the socket of the glenoid of the shoulder blade has popped off and with its attached ligament, and you can also see a little indentation within the head of the humerus called a Hill-Sachs lesion. Those two things combined can allow that ball to slide out of the plate again, and if those are large enough, it may not heal appropriately. On the far right image here, you can see a Bankart lesion on an MRI where both the bone as well as what's called the labrum, which attaches around the side of the bone, kind of like a suction cup that holds the ball onto the socket. Both of those have been pulled apart and there is a fluid line going through there. And of course, that's allowing that shoulder to slide ever so slightly out of the socket there. So when does that happen? Well, certainly it can happen at any age. It is a little more frequent in our younger children just because the overall size of the glenoid is much smaller than it is in an older teen. So it doesn't take too much of an injury to result in instability. So our younger children with dislocations tend to have higher recurrence rates than our teens and older kids. But of course, multiple dislocations is a risk factor for having another dislocation. So the more you slide it out, the more of these injuries can occur and the larger the lesions can be. And it may result in a surgical need to fix that. However, even after a second dislocation, if the patient is improving, we can try physical therapy to help strengthen the rotator cuff. So even if the joint is unstable, if you add stability by strengthening those rotator cuff muscles and pull the ball back onto the socket, it may provide enough stability to get the patient back um, to sports. If, however, that's not improving, well, then the old standby MRI, like you can see on the far right, is usually necessary. So what type of surgeries do we do? Well, there's a few different things that end up happening with these dislocations. As you can see at the top image, what we have there is a fairly soft tissue only injury. That little suction cup has been pulled away from the rest of the glenoid. We call that a labral tear. And on the far right arthroscopic image, you can see sutures that are reattaching that labrum to the bone itself. Now, down in the bottom, I don't have any Bankart bony repairs in my collection. I don't see too many of those, but that's the whole idea. Not only are you repairing the labrum, which is a little soft tissue rim, but you're also trying to fix the bone either through sutures or sometimes even with little screws that you drill the two halves of the bone back together to provide that stability. What about those little Hill-Sachs lesions? Well, sometimes we can just leave those alone if they're small. However, if there's a large indentation in the back of that humeral ball, and then you rotate that shoulder back into this position, well, that allows that little lesion to slip off the front edge of the shoulder joint. And if it's between about 20 to 40% of that head that's indented like that, you may require some surgery to, believe it or not, tack the muscle down into the back of that little lesion. Call that a remplissage procedure. Basically is tightening the joint capsule into the lesion. It's going to result in decreased motion in the shoulder, but it'll hopefully prevent it from popping out again. And then in really large lesions, like greater than 40% of the surface, sometimes we just have to stuff some bone or even some metal block in there to prevent it from popping out. Of course, that's really detrimental to shoulder motion and can result in some wear and tear as well. So it's a kind of a last-ditch salvage procedure if there's a large Hill-Sachs lesion like that. All right, getting into our fourth most common injury, what we call the AC sprain or acromioclavicular joint. Again, just like with previous injuries, it tends to be the fall onto the shoulder, usually with the shoulder kind of pushed inwards, what we call the adducted position. You can see on that far right picture that that collarbone doesn't really line up with that acromion. That collarbone is higher than the acromion, and that's because those two bones have been stretched enough that it tore the ligaments, not only that attach the collarbone to the acromion, but a little projection that sticks up there called the coracoid, which you'll see on the next slide, I believe, or is the slide after? Yep, nope, next slide. So what is the AC joint? Well, like I said, it's the joint that connects the collarbone to the acromion, but it also is connected to the shoulder blade too itself through a couple of other ligaments called the coracoacromial, meaning connecting the acromion to the coracoid, that little kind of Cheeto-looking structure that comes up from the front of the shoulder, but also the coracoclavicular. So there's multiple ligaments that attach the collarbone down to that coracoid, and that's when those are injured, that's what allows that collarbone to pop up so far. So, what do we see on exam? Well, usually the collarbone's sticking up a little bit, or at least slightly more prominent on the side of the injury. And if you take the patient's shirt off and you look at both of their AC joints, you can see it sticking out a little bit more, or at the very least that there's some pain when pressing on the area. Of course, it also hurts when you rotate the shoulder and significantly when you reach across to touch your other shoulder. That really puts a lot of stress on the AC joint. So you can see here what we do to work these up. What I like to do is called an AC series, where you get x-rays of both collarbones on one cassette, and then you look at a distance between that little coracoid process and the collarbone, and you can see on the right side of this picture that that distance is about twice what it is on the other side. So we would call that greater than 100% displaced, and that would be you'll see on the next slide, a type 4 AC sprain. Of course, we also need to do MRI if we're thinking surgery. And here on this image on the lower left, you can see a significant amount of white fluid around that AC joint and even in the bone, indicating that those two structures have been stretched a little bit. In this case, it's not significantly separated, but there's definitely at least a grade 1 AC sprain on that MRI. So what type of AC sprains do we see? Well, like on that MRI, grade ones, just where there's stretching of the two bones just a little bit apart, tends to be painful, but not anything that's going to require surgery. Our type twos, where they've spread a little bit, but not too far, we will of course treat those non-operatively as well, and generally usually a sling for about 1 to 3 weeks, depending on the severity, and occasionally some physical therapy if it's bad enough. And generally for the type ones, they're usually back to sports within 4 to 6 weeks, and the type twos may even take 2 to 3 months. Now, the upper right half there, we have a type 3, which is our controversial injury, where it's separated enough, but not all the way. And occasionally, we can treat these operatively or non-operatively. It depends on the patient's age and the amount of sports that they do, or what type of sports they do, more importantly. Now, in the lower half of this picture, you can see the type 4, where the collarbone, instead of separating superiorly, is actually separated front to back. And those are a lot harder to see on an x-ray, and sometimes will require a special axillary x-ray to see the displacement. That you can see in the inset image there in the lower left. We're looking at the shoulder from the top down view there. Those can be very subtle, but unfortunately also something, if missed, is going to be really problematic in the future, because it's really hard to relocate those if you wait too long. And then in the lower middle there is that type 4, where those two bones are really separated. And of course, those aren't going to heal without bringing things back down. And then finally, the type 6, which are extremely rare, it's where that shoulder blade actually goes down instead of up. And that really takes a blow on top of the shoulder to create that. So those are pretty rare, but tends to happen with a head-to-head collision in football, where the helmet, instead of hitting the other person's helmet, actually hits onto the top of the shoulder. Of course, that's why we have shoulder blades, is to prevent injuries like that in football, but it can happen in rugby and other less padded sports. So how do we treat these grade 4, grade 5, and grade 6? Well, there's a lot of different ways to do that. In general, we are, of course, trying to repair the ligament that connects the collarbone to the acromion, but we're also trying to bring that collarbone back down. So it usually requires some form of tethering to connect that collarbone down to that little Cheeto-looking structure, the coracoid process. There's a lot of different ways. Weaver Dunn used to be the mainstay of how we treat these, where you repair the ligaments, you transfer one ligament to another spot. In general, though, that's fallen by the wayside, and we tend to do a more anatomic repair as well as augmentation, where we reattach that collarbone down to the coracoid, either using a suture, using wires, or sometimes even just a tendon graft from somewhere else in the body or from a cadaver. And you can see in the upper three images the different ways in which you can tether the collarbone down to that coracoid process. In the lower image, if you look on the right side, you can see that there's elevation of that collarbone off the acromion. And then in the lower image, there's a little metal, it looks like a coin sitting on top of the collarbone. That's actually a little button that has sutures attached to it, and that's drilled down into the coracoid to reattach that collarbone and re-anchor it there to prevent it from popping up again. Obviously, with surgery, we're going to have some immobilization, usually a sling post-operatively, and then, of course, full return to sports takes significantly longer, usually on the order of 4 to 6 months, missing a good chunk of a season depending on when the injury occurs. Usually, the return to motion happens a little bit more quickly, somewhere around the 6 to 8 week mark. And then finally, I'd like to talk a little bit about little leaguer shoulder. As I said before, not really necessarily an acute injury, but it really is some trauma that occurs to our shoulders, and it's really only a pediatric sort of injury. It doesn't happen once the growth plates close. So what is little leaguer's shoulder? Well, as opposed to what you see here on the far right, this is of course a major league pitcher, but it is essentially a repetitive micro trauma. The more that shoulder gets pulled backwards, the more it pulls on the front of the growth plate. And if you do that repeatedly over a short period of time or for long periods of time, it will cause the growth plate to get overloaded and the growth plate will start to stretch slowly apart, essentially a fracture in the making. Generally, my kids will complain of it hurts, it aches after throwing in the front of my shoulder. But oftentimes it's subtler findings with some weakness and really decrease in velocity, especially my older teens who are they're actually going to pitching coaches and having their fastball timed or radar gun to see what the pitch speed is. And then, of course, the change in throwing mechanics where kids start drooping shoulders, start having a different wind up to accommodate for the discomfort that they're having. So, what is that part of the throwing motion, and why does it happen to pitchers and not necessarily quarterbacks or other sort of throwing athletes? Well, if you look there, right in the middle there, what's called the late cocking phase, where that shoulder is really far backwards, that's something that really only occurs in pitchers and to a certain extent quarterbacks. That extreme amount of external rotation there to try to generate the torque as you come forward really puts a lot of stress on the growth plate in that proximal humerus. So, what is little leaguer's shoulder? Well, we call it proximal humeral physis or proximal humeral epiphysiolysis. Basically, the growth plate's getting stretched apart. The growth plate is in a tug of war. The rotator cuff muscles are pulling the humerus one direction. The deltoid and the pec muscles are pulling the humerus in the other direction. And over time, that growth plate just starts to get stretched. You can see in the lower image, we're comparing the right and the left shoulders, and that right shoulder has significant widening of the growth plate along the outside compared to the other side. In the upper images here, you can see a similar x-ray with that widening, and then you see on the MRI, all that white stuff is fluid. It's your body responding to the injury. It essentially looks like a broken bone on the MRI, even though it looks really subtle on the x-ray. Kids are in a lot of pain and unfortunately require a lot of time to get over these injuries. So, how do we treat little leaguer's shoulder? Well, if a child is only having a few weeks or maybe a few days of pain, usually it just starts with a little bit of rest. Stop throwing for a bit, especially if you don't see any of the widening of the growth plate. I'll be honest, most of my kids with little leaguer's shoulder, even the one I just saw about 2 hours ago, you don't see that sort of widening. They just need a break for a few weeks, stop throwing, and then start a little light toss program and get them back to it. However, when you do see that growth plate widening like that, those kids need an off season. They need a break. They need 2 or 3 months off where they're not throwing to allow the growth plate to recover. So down below, we have a few different suggestions. Unfortunately, none of our kids tend to follow them, but certainly avoiding pitching on multiple teams. Well, that's pretty much every pitcher in the state of New Jersey. Pitch count certainly has gotten a lot more play with amongst the coaches, and I do think kids are trying to adhere to it. But it can be difficult when you're on 2 or 3 teams and pitching for all of them for all the coaches to kind of keep track of things. And of course, the final kind of recommendation from USA Baseball is that kids need 3 months where they're not throwing. They need an off season. If adult pitchers need off seasons, why don't kids? Unfortunately, most kids don't have off seasons any longer. As far as pitch counts go, of course, it increases as kids get older, and our really young ones shouldn't be throwing more than about 50 pitches a game. Our older teens, more or less, are like adult pitchers and are able to throw into the triple digits. And of course, also, how often are you allowed to pitch? Well, the younger ones, as you would expect, you're not going to be throwing nearly as much, but depending on how many pitches you throw. If you throw more than 66 and you're under the age of 14, you need basically an adult pitcher's break. You need 4 days off from throwing. Unfortunately, it tends to be most of these kids, especially for their travel teams, have tournaments where they kind of go in spits and spurts where they play 5 games in one weekend and then they don't play for another week or so. So they get this burst of overactivity followed by a little bit of a break before they do it all over again. And they're not really able to recover from these things. And then finally down here in the bottom half here, you can see all the different bodies that try to give recommendations for pitch counts and pitch types for kids. So there's endless number of studies and different recommendations that you can go through to look at that. And then finally here, pitch selection, something that's become a little bit more controversial in the last few years. because kids start throwing a lot of breaking balls before they really should be able to do so. In general, our breaking balls, our curve balls, or sliders, you really shouldn't be doing that until you're in high school. But I would say just about every 12-year-old is at least throwing a curve ball, and some of them are even throwing sliders, and that really it increases the amount of torque when you're putting your arm at that angle to make that pitch. And It's really problematic for our little ones. We certainly see a lot of elbow issues from this as well. And if anybody is following Major League Baseball, there's been a epidemic of Tommy John's ligament injuries and Tommy John's surgeries because of the amount of torque and spin that a lot of these major league pitchers are putting on the baseball now. There's a lot of research that's going into it, but at least in the pediatric population, we think that a lot of it has to do with the built up trauma as kids. It results in a lot of scar tissue forming, even though it's the growth plate that's inflamed in kids. There's scar tissue that forms to heal that injury. And then as they become adults and those growth plates start to shut down, those ligaments are never like they were even before the injury. And that's what we think may be resulting in some of these high school and even college pitchers getting Tommy John's tears and having to have surgery before they even make it to minor league, let alone to the pros. But that's probably another 10 or 15 years away before we'd be able to prove any of that. But at the rate that kids are increasing the amount of baseball play, it may be too late by the time we actually have the research to prove our theory, because kids are just doing a lot more baseball than they did even 10 to 15 years ago, let alone when I was that age, which is 30 years ago. All right. And then our final slide here, just a list of our different providers here. Both myself on the far left, as well as Dr. Haynes and Dr. Lentz. We are pediatric orthopedic surgeons, and we typically treat both adolescents as well as teenagers, although some young adults as well. And then you can see our 6 locations, hopefully soon to be a seventh location coming soon, perhaps up in the East Brunswick area. And then, of course, we offer physical therapy for all our patients at all 6 of our offices, and be happy to have you stop by. So that concludes my presentation here, and I'm happy to hear from everyone else, any questions that you may have, and I'll open up the floor to everyone else.
Thank you so much, Dr. Collins. It's interesting to me that more kids are playing baseball now. I would think that other sports are like growing in popularity, but I guess not.
Oh, they are. Certainly, soccer is by far the next most common one that's growing in popularity. And then all our MMA athletes, of course, usually they start out at wrestling and then add in the jiu-jitsu and got a lot of shoulder injuries from that as well. So there's a lot of emerging sports out there that are causing injuries that we didn't necessarily have training for back even 10 years ago when I was doing my pediatric fellowship. So we're constantly trying to learn new things. What did I learn about today? Bowling injuries and knee. So there's a lot of bowlers apparently at one school. There's apparently a bowling magnet school out in the community here in Jersey Shore. So learning a lot of new things on a constant basis, it seems like in my practice.
That's funny. Bowling is definitely growing.
Yeah.
All right, so if anybody has any questions, like I said, you can feel free to unmute your mic if you feel comfortable in asking your question. If not, you can type it in the chat below and I will read it. So I'll give everybody a minute to type or feel free to unmute. Okay, so we have one. Forgive me because I don't know what this is. I had a later jet done
Ladder
two
J. Yeah,
weeks
I
ago.
know. I
Gotcha.
can see here. Yeah, a ladder J procedure generally is something that we do when we have recurrent instability that doesn't um, heal properly after a Bankart repair, or even if the Bankart fracture doesn't reunite, you have to put something there to keep the ball from sliding. So usually we'll take a portion of that coracoid where that ligament attaches, and we can actually slice it off and reattach it as a block of bone just to add extra joint the surface to prevent it from sliding out. I haven't had one myself, and I certainly don't usually do it as part of my practice, but I have 4 or 5 sports colleagues that typically do that quite frequently, or not quite frequently, but frequently when it's necessary. But usually a sign of a lot of recurrent injury or really nasty shoulder dislocation, something traumatic like a car accident or a fall from height, where it results in a really large fracture that doesn't heal, or unfortunately, sometimes injuries that aren't picked up and not worked up appropriately.
Wow. So Troy asks, is it realistic that he can return to weightlifting 100%?
Hmm. I can't imagine 100%, but I do think it should be increased emotion. It kind of depends on what sort of weightlifting you do. I would assume things like pull downs and squats and deadlifts are going to be pretty difficult because that puts that shoulder into the externally rotated position. But I think benches, curls, triceps, all of that should be reasonable return, of course, once the pain is under control. So I think there's reasonable improvement without seeing the films myself and knowing exactly how they did the Latarjet procedure or what other additional procedures they did. It's hard for me to tell you that. One of my adult sports colleagues may have a more insight into that, and I'm not sure who did your surgery, but you can always ask your surgeon as well.
Awesome. Kathy had just asked if we're going to be sending the slides to everyone, and yes, we are. I'm going to send the full presentation over to you guys. That'll probably come out like tomorrow morning.
Gotcha.
Do we have any other questions? So Jay says, I had an MRI on my left shoulder. It showed nothing was wrong, and x-rays shown good bone spacing. Doctor said it is the end of collarbone that is inflamed but still hurting.
Yep.
I'm not sure if
Yeah.
he's typing.
Sounds like either some chronic. Uh, Okay. Well, I'll try to answer that question. Sounds like some AC joint pathology. Sometimes it's not necessarily a sprain. You can have chronic stress there that can lead to some arthritis, depending on the age. Occasionally, you can go in and do a subacromial decompression, where you go not into the shoulder joint itself, but in the interval between the acromion and the ball of the humerus, and put in a little shaver and go into the AC joint and shave out some of that arthritis. Last ditch, you can always do what's called a Mumford procedure, where you actually remove the end of the collarbone so that it doesn't actually form any inflammation there. If you get rid of that, then the acromion's just kind of hanging by itself, and there's nothing for it to push up against, causing any discomfort. As far as injections go, yeah, an AC joint injection is certainly doable. A cortisone shot, I would assume, is what they meant by injection, and that's can decrease inflammation in the area, both in the AC joint, but oftentimes they'll do a little subacromial injection as well in addition to that.
All right, so we had another question. Do you think that focusing more on increasing muscular strength or flexibility for a greater ROM would be more beneficial in decreasing rate of injuries?
I think strengthening, absolutely. Rotator cuff strength certainly tends to be a little lacking in most younger patients. It's not something they do a fair amount of. So a lot of these injuries are, more or less instability things. And if you add additional strength, that can prevent some of these episodes from occurring. As far as stretching, yeah, certainly pre-workout stretches. As far as, like doing formal therapy or range of motion. I have some kids who do a fair amount of Pilates and yoga, just something to increase flexibility. And that can prevent muscle injuries. If the muscles are a little bit stretchier, they tend not to get sprained as much. It's not necessarily going to change the joint itself. Could stretch out the capsule a little bit if you had a tight shoulder joint, but in general, you don't want a loose shoulder joint. You prefer it to be tighter. But as far as preventing injuries, I would think strengthening exercises is probably more benefit.
Mm. All right, awesome. Do we have any other questions before we end things for the night? If you come across a pediatric clavicle/shoulder injury, what do you recommend as first aid before they're seen? Stabilize, apply a string if available, sling.
Yeah, sling if you can, or sometimes you can actually just take a strip of fabric, you loop it around their neck and around the cuff, the wrist joint, just to kind of keep it stabilized. They tend to be more comfortable when things are hanging up as opposed to drooping down and pulling the neck with it. If you see a noticeable deformity, you don't want to try to reduce it. You don't want to push on the fracture because you could result in it piercing through the skin and creating a much more urgent surgical problem, what we call an open fracture, where the risk of infection can get significantly higher. But yeah, some form of immobilization. It's hard to put a splint on a collarbone fracture, but something to just make the kid comfortable. Looks like we got another one. Do you have any suggested warm-ups for pitchers for middle school? Yeah, our shoulder presses. It's going to be hard for me to show on camera, but basically going up against the wall and then you're working your arm up the wall, trying to stretch out the posterior capsule, and then just the gentle kind of what we call the windmill effect, just to kind of stretch out the anterior capsule there. It's really nothing all that serious. And then, of course, the behind your back, you'll stretch out the anterior capsule as well.
All right, we have another one from Hannah. What are your opinions on KT tape with shoulder injuries when in the recovery process?
Ooh, if you can explain to me how KT tape is, I can give you part of my practice because I don't exactly understand the taping. The idea is that it's going over the skin and preventing joint motion in ways that you don't want it to. I've seen, at least a dozen different YouTube videos that show me how to properly apply KT tape to the shoulder, and they all have different ways of doing so. The idea here is to prevent excessive motion for people that have hypermobility or aches and pains. I've seen some who have actually applied it to the AC joint, trying to kind of squish down that collarbone after a sprain. I haven't found KT tape to be very effective in my practice, in all honesty. At the same time, if you look at any NBA game, you'll probably see at least two or three of the pros with K tape somewhere or KT tape somewhere around the elbow or the shoulder. So there must be some science to it, but I haven't found it to be very effective in the pediatric population, at least in my practice, in all honesty. Some of the trainers may be able to chime in and give me a lesson here. I'm happy to learn. Perhaps there's something I'm not doing right about it.
All right, so our same ladder J patient from before says, will doing more PT than I'm recommended increase my chances of obtaining full ROM? E.g., they
Uh,
say 3 months and I do 4.
I'll be honest with you, the goal of Ladder J isn't necessarily to have you back to full preoperative range of motion. The goal is to keep your shoulder from popping out of the joint. So you were adding extra bone where it wasn't already there. You're going to have a little bit of stiffness, and I think that's actually a fair trade-off for a shoulder that doesn't dislocate. I do think there's benefits to be had. It is a significant bony procedure with a lot of soft tissue dissection. So I do think you can still see benefits even up to a year out from the surgery. And I think even 6 months is probably a still some benefit that can be had from further physical therapy. Of course, in our American healthcare system, sometimes our insurances fight us with that. I had ran into that issue earlier today with one of my knee surgical patients who unfortunately got dropped from his Medicaid insurance. At the end of the day, there are still benefits to be had, I think, if you're that far out from surgery. No, I don't think that's the final amount of motion you're going to have. Continue on with it, and I think you can still get some benefits, but you don't want to increase motion to the point where it pops out again because then, well, what else? We've already done the salvage. If you're at a ladder J procedure, next step is shoulder replacement, and depending on your age, that may not be a very good option for you because that's definitely going to decrease the amount of function you have in that shoulder.
All right, awesome. I'll give one more chance for questions, but I think we've covered a lot of great questions. Thank you, everybody. All right, so I think we'll call it there. So I just want to say, if you have any unanswered questions or concerns, Dr. Collins is accepting new patients. You can book with him online at cviewortho.com with our virtual assistant or by calling us at 732-660-6200. We have also recently had, in some big news, extended our Ocean office hours. So if you are near our Ocean Township office, from 5 to 8 p.m., Monday through Friday. We are open for walk in visits for immediate care. You'll be seeing our PAs. So you can check on our website under Seaview Ortho After Hours. You can click on that little green button and learn all of the information there about that if you have any urgent orthopedic issues and don't want to go sit in the ER waiting room. So if you did hop on late and miss my intro, I'm just going to go over everything again. We do these virtual education seminars every other month. Information can be found on our website under upcoming events. And the best way to stay up to date on all things Seaview Ortho is to follow our social media platforms. We are at Seaview Ortho on Facebook, Instagram, TikTok, LinkedIn, and YouTube. We also have a podcast, the Seaview Ortho podcast, that you can find on our website. We just did a really interesting episode with Greg from the Jersey Shore Blue Claws. If nobody knew, we are the official team physicians for the Jersey Shore Blue Claws, which is amazing. And of course, you can also sign up for our newsletter at cviewortho.com to get all of these wonderful things sent straight to your email. So, once again, check your email, I'd say tomorrow morning, and this presentation will be sent to you in case you want to rewatch or send to a friend. And thank you again, Dr. Collins, for giving us your time tonight. And thank you to
You're
everybody
welcome.
who logged in. We really appreciate it.
All right. Have a good night.
Thank you.
Bye, everyone. Enjoy this beautiful night.
Okay, thank you. Bye.